Good evening, everyone, and thank you for joining us today. We are excited to have you all here for another wonderful patient webinar on lens implants for cataract surgery in 2025. My name is Gabriel Macias, and I am the Business Development Manager for Harvard Eye Associates. It's my pleasure to introduce our presenter for the evening, Dr. Behnaz Rouhani, cataract, cornea, and refractive surgery specialist. Dr. Rouhani is a board-certified ophthalmologist specializing in cornea, cataract, and refractive surgery. She specializes in treating corneal disorders, including ocular surface disease, corneal dystrophies, and laser vision correction. Additionally, Dr. Rouhani is board certified in internal medicine, which allows her to consider broader health implications for her patients. She is a diplomat of the American Board of Ophthalmology, a fellow of the American Academy of Ophthalmology, and a member of various professional organizations. Dr. Rouhani has contributed to numerous educational presentations and publications in the field of ophthalmology, and her techniques, compassion, patient-focused approach integrates the latest techniques in eye care. Dr. Rouhani, thank you so much for being here to host tonight's patient webinar.
Thank you. Good evening, everyone. Thanks for joining us tonight. I'm very excited about this topic. I know a lot of you may want to know more about the available lens implants and technologies in 2025 in the era of technology that we're living. So I'm going to briefly go over what the cataract is and what cataract surgery involves. Cataract is the clear lens of ours, which is located right behind the iris, which is the color part of the eye. As we age, this clear lens becomes a little cloudy, yellow, and in advanced stages to brown and darker or brown, not letting us see objects as we used to see. Cataracts are the leading cause of vision impairment globally. And cataract surgery involves the removal of the cataract and the cloudy lens and replacing it with an artificial intraocular lens implant, which helps us restore our vision once the natural lens is removed. So there are different types of lens implants, which I'm going to go over each in a few seconds. It's very important to choose the right implant for each patient. So during my appointments with my patients, we see a lot of patients who are very worried about what type of a lens they need to choose when they're going through cataract surgery. So there are different types of lens implants. Monofocal intraocular lenses, they correct for one focal point, usually distance vision. And patients may need glasses for reading or intermediate vision. They have pros and cons, which I'm going to review with you in a few minutes. Multifocal lens implants, they correct multiple focal points at the same time, reducing dependence on glasses. They're ideal for patients who want both near and far vision correction. And then toric lens implants, they are there to correct astigmatism in addition to the cataracts. They are customizable to meet individual needs. And we have EDOF or extended depth of focus lenses that they provide a continuous range of vision, enhancing intermediate and distance vision. They offer a reduced risk of visual disturbances that we see with multifocal lenses the most. And they're ideal for active lifestyle. Given all of these lens implants that we have available, we have to keep in mind there's no perfect lens implant. There are advantages and disadvantages with any of the available lens implants. The key is to find a right match for the patients. And that depends on a lot of things that we need to take into account. So we have innovations going on in lens implants in 2024 that we are very excited about. There are advanced multifocal designs nowadays that they reduce glare and halos that we used to see with the older version of multifocal lens implants. They enhance near, intermediate, and distance vision more than what we had available in 2023, 2024, and of course, years back. They're more tailored design based on the patient's eye anatomy and visual needs. And there are a lot of new materials being used to improve biocompatibility and acceptance of our body to them and reduce risk of complications. And they're mostly designed in a way that they can have an extended lifespan. So proper selection, as I mentioned, is very, very important. If you are about to go through cataract surgery, or you're considering cataract surgery, you probably have found yourself having difficulty to make a decision on which type of a lens implant would work best for you. So the very first thing that I always tell my patients that would be best and it would help them to make the right decision is to find out what they expect and with cataract surgery, and what are their individual vision goals, lifestyle, hobbies, leisures, job requirements. These are all the very important factors that you need to look into that. Specific eye conditions such as advanced macular degeneration, glaucoma patients, especially with the advanced stage, diabetic retinopathy, and corneal dystrophies are not good candidates for multifocal or high and advanced technology lenses. So just moving forward with an advanced technology lens does not necessarily mean you're going to have an optimized visual outcome. So finding a perfect match for your eye is the key. And of course, consulting with your ophthalmologist and surgeon is really crucial to discuss options that would greatly fit your expectations. And of course, looking at the overall health of the eye is the key on behalf of your surgeon. So how I actually divide the lens implants is, and how I look at it is based on two categories. We look at the lenses that they provide you with maximum quality vision, and then we look at the category of lens implants that they provide maximum range of vision. The trade-off is between vision quality and glasses independence. So balancing quality and range sometimes could be difficult for patients because you might think, okay, I want a great quality, I want a perfect nighttime vision, I want a least amount of glare or halo as possible, but at the same time, I want to be independent, and would like to avoid wearing glasses, and that's sometimes hard to achieve. So, and I will kind of like review a few things with you to make it easier for you to make the decision. So that's my recommendation, to sit down with yourself once you have your appointment with your doctor, once you talk about cataract surgery, what it involves, what you talk about, different lens options that you would be a match for. Think about what would you expect the most and what would suit your lifestyle the best. So my top picks for maximum quality of the vision are what I have mentioned on the slide. So the light adjustable lens and light adjustable plus, they're the best available nowadays. The only lens that is FDA approved to provide the highest quality. However, you need to know that these are not multifocal lenses, and there's always a chance of having the need of readers. So if you find yourself really be very in need of a highest quality, especially nighttime vision, least amount of glare or halo, if any, but you take the chance of needing readers, then I would go with light adjustable lens. Okay, there are also some certain conditions that we need to take a look at and make sure the light adjustable lens would be best for you medical wise. However, if everything is fine and you're a candidate for a light adjustable lens, that's the best out there now to give you the highest quality possible. The next that I would go with is Aspire lenses from Bausch & Lomb company. Aspire lenses, they come in monofocal Aspire. They're monofocal. They're kind of like designed to give you mostly one focal distance vision.
which we mostly push for far distance, but they are kind of like designed in a way that they can give you some range. And intermediate vision in most of the patients is very good. And that's why our toric lenses are great, because they can not only give you a better, brighter vision, but they can also correct for your stigmatism. Basic monofocal lenses, as I mentioned, Eyehance is a J&J lens implant that kind of like I used to use them, and then it was pretty good with giving some range, some depth of focus. However, the results were inconsistent. Some patients would be really happy with the intermediate and distance vision, and some patients would have only good distance vision, but requiring, readers or computer glasses. Now in 2025, we have Aspire from Bausch & Lomb that gives perfect distance vision. I mean, close to perfect, I should say. There's no perfect lens, but this is one of the ones out of monofocal category of lens implants that will give you really high quality vision, no glare or halo, and some range of vision, mostly intermediate. And then for fine print and reading, you might need up to upper readers. And another one that I found to be having a maximum, kind of like a high quality vision is IC8 Apthera lens. Again, it's from Bausch & Lomb. This is great for those patients who are very light sensitive. It does have a central dark area. And for those who have bad irregularity or irregular astigmatism. As far as the top picks for maximum range of vision, meaning are we looking into really avoiding wearing glasses as much as possible? And if you're a candidate for what would be the best out of the wide variety of lens implants now we have, which can provide that to you. And Vista NV is new as of 2025. That is technically a trifocal lens. The older version from Alcon company was Panoptics. We still have Panoptics, so we still use Panoptics, but in Vista NV is sort of like same sort of a design as Panoptics, a trifocal giving you distance, intermediate, and close-up vision. However, with the least amount of glare and halo as opposed to Panoptics. Odyssey is also a new lens implant that we've been using in 2025. It's kind of like a more of an extended depth of focus and give you some range. This is from J&J company. And again, this is one of those lenses that we are seeing pretty good, amazing results, but there are some that we have found that there is a chance of need of readers for very fine print. And that's kind of like the same with Vivity from Alcon that I have been using pretty often and with amazing results. But what we have found to do to provide the patients with the least chance of needing glasses is to make the dominant eye pretty perfect for distance, and so push for perfection, close to perfection for distance vision for the dominant eye, and then for the non-dominant eye, we push for less of a perfection for distance so we can achieve some near, and that has been pretty successful in providing patients with less dependency on needing readers. Light adjustable lens plus, I put it in both categories, even though it's not a multifocal, it's not an extended depth of focus, but it is shown to provide you not only with maximum quality, but some range or some depth of focus. And then Panoptics, again, as I talked about it, it's a trifocal. Now with new innovations in 2025, we're kind of like moving towards using lenses that provide the least glare, least halo, or least visual disturbances that patient has kind of like experienced in the past with the these type of lenses. So before I move on to explaining a little bit more about the technologies that we have available, I just wanted to emphasize how important it is to find the right, appropriate lens based on your needs. And the surgeon also needs to kind of share that with you after complete cataract evaluation is done. The whole complete health of the eye is evaluated to let you know if you are a candidate for what you feel is the best for you. A lot of patients come to me and say, okay, you know what, putting insurance costs and everything aside, I want the most advanced technology. That doesn't necessarily be the best for the patient if there are other pathologies going on. So history of LASIK, PRK, RKs, and as I mentioned, retinal pathologies, cornea pathologies such as Fuchs dystrophy, other dystrophies, scars, cornea scars. There are a lot of things that we as surgeons look into just to make sure that we choose and select the most appropriate lens for you. The key is to choose a state-of-the-art technology for you and to provide you with the best visual outcome. So remember, there's no perfect lens implant, and there are risks and benefits to each. But we're very hopeful in 2025 as technology evolves, we're seeing a lot less of visual disturbances with the technology that we have available now in inventions and innovations for lens implants. So as I talked to you a little bit ago, light adjustable lens technology is an amazing technology that is approved as of, I think if I'm not wrong, it was 2020 that we have it approved, and we started using it with amazing results. It's the only lens implant that we have available that is FDA approved, and it's adjustable after surgery. So what we do 3 weeks after both eyes are done. So technically I do cataract surgery in one eye and then the other one in a week apart. And 3 weeks after the last eye is done, we're going to start, once we achieve the stability of the vision, we start treating the lens implant with UV light to shape it in a way that provides you with the best vision. The treatment will take about like a few seconds to a few minutes each session. Somewhere between 3 to 5 treatments are required to complete fine-tuning to where you are the happiest ever with your vision after a long time. And as I said, it's the most precise lens implant available. The highest rate of achieving 20/20 vision is with this lens. It's perfect for patients who have had LASIK, PRK done in the past, and there are more at risk of developing halos or glare after surgery, and they prefer to avoid those. And this is the perfect lens. But again, if that is only if you are okay with readers at times. So LAL Plus offers slightly more depth of focus, as I explained to you. And at the end of the day, you just need to sit with yourself and say, okay, would you mind just grabbing a reader and put it on and read? Now, I have to, however, add this. With light adjustable lenses, what we can do at times is that we do what we call it mini monovision, not to make the dominant eye for distance completely and take away the distance vision from non-dominant eye and give you only close-up vision, but we can do like mini monovision, meaning we can give you less than 20/20 for the non-dominant eye, so give you some near vision. And that has been working pretty well with my patients. And rarely I see that they say, okay, they have to grab a reader to be able to read. But again, it's just your preference, and you see how you would want to proceed if you will be in need of glasses. So
As I explained to you, maximum range of vision options that we have now available. Of course, there are a lot of lens implants beyond this talk, but I kind of like pick and choose what I have been using, what I have used in the past, and what I feel is very exciting in this year and the few months to come. So VVD Panoptics Clearview 3, sort of more newer than Panoptics and Vivity, and that is also a pretty good lens to provide range of vision. However, we have to make sure that we pick and choose right cases. Those who have a lot of astigmatism, Clearview 3 is not a good idea, um, not a good selection, and it can provide produce some sort of a glare or halos as well. So as of now, the 2025 lens implants that have been out and have been shown to really reduce the visual disturbances and taking care of the technology or more advanced technology to kind of like minimize the problems that we have had with other lenses in the past, our Odyssey and Envy. Again, we just want to make sure that we choose what would be the best and lower the chance of having halos or shadows. Okay. And then it comes to this question of how much would you tolerate minor visual disturbances? Having said that, a lot of these, lenses, when they cause this visual disturbances such as halos or glare, will subside after some time, but it may take a few months. That's why we say, making that decision of how much you could see yourself tolerating this little imperfections it's the key. And it kind of like helps you recover a lot faster after surgery. So as far as the clear view goes, I actually told you about it. It provides good vision at multiple distances. Now, there are less severe nighttime halos as opposed to panoptics, okay? But limitations are there. They're not available as toric or astigmatism correcting, all right? And then there's a limited power range that we can provide to patients. So some patients may notice shadows, some patients may notice halos, and those who are very severely nearsighted or those who have high level of astigmatism are not great candidates for clear view. And that's another example of what we say advanced technology does not necessarily mean they're perfect selections for specific patients. Panoptics provides wide range, it's mostly trifocal, but it has been shown to cause a lot of glare or halos. Vivity is extended depth of focus lens. It's very forgiving. Out of all of the three, I should say, and the older versions like Synergy, Symphony from J&J is the least to cause glare or halo. But again, it's the one that has been shown to kind of like give the real kind of like need of readers for fine print. And as far as Envista and V goes, the technology available now has been trying to kind of correct whatsoever issues we had with other trifocal lenses, now incorporated to the new lens, which is now Envista NV, to not only provide the good vision, trifocal, kind of like three different kind of like distances, far distance, intermediate distance, and near vision, but also have the least halo or glare because of the, cutting edge design that it has, okay? So it is one of those ones that we are seeing that patients will have the least need of glasses, if any. J&J Technics Odyssey, as we spoke, is kind of like a lens that gives us range. But again, I have seen some patients might need readers with some fine print, or those who are avid readers hourly, not hourly, they kind of like read for hours, I should say. They would need readers because they might get a little tired. So the key points, again, there's no perfect lens. Each has advantages and disadvantages. Matching the right lens to each patient is the key. what would you prioritize as your goal? Is it your vision quality or glasses independence? So I always ask my patients, you want to go with the highest, quality, but chance of needing glasses wouldn't bother you, or you want to go with maximum range, accepting that the night vision is not going to be as great as this one, but you would be having at least chance of needing glasses. And sometimes this would be very difficult for patients to make a decision. That's the beauty of having a lot of options and advanced technology these days. But realistic expectations is the key, all right? And then a lot of lens implants are available in 2025, and we are expecting even more to come in the next few months. And conclusion. Before I actually get to this point, I just wanted to share with you. A lot of patients come to me and say, okay, I just want a cataract surgery. How come it's taking like about half an hour to do all of these detailed examinations, all of these imaging, all of these tests? Why? It's just my cataract and I want my cataract out. That is the reason. So every cataract evaluation might take quite a bit of a time for the surgeon to evaluate every part of your eye. And the reason is because not only we want to make a right decision and get that surgery done in a timely fashion for you, but also we want to choose the perfect lens. The perfect lens for you is not necessarily the most advanced technology, but what matches your expectations and overall your eye the best. So we are very happy that we're living in an era that we have multiple choices, the highest technology available. We have access to that. And 2025 has marked a shift toward more customized and high performance lenses. The future obviously holds promise for further improvement in technology. And as the technology progresses, cataract surgery outcomes are much better than before, enhancing patients' quality of life. And again, while there is no perfect lens implant, finding the right lens implant for you is the key. And if you have trouble making the decision between going with the maximum quality or maximum range, go with maximum quality, okay? And setting aside the cost and insurance coverages, I think if someone would have asked me what I would have done for myself, and again, this talk has no sponsor, I have no financial, interest in with any of the lenses with any other companies. But just out of experience and what we have available, science and technology behind these lens implants. If I had cataracts and I had to go through cataract surgery and I had trouble deciding between all these technologies available, I would definitely go with light adjustable lens. Especially light adjustable lens plus is one of the best to achieve not only the great nighttime vision, not only the great contrast vision, but least, if any, amount of visual disturbances such as glare or halo. Now, some patients are not a candidate for. So if you have eye pathologies, just go with the maximum quality lens implant that will provide you with the best vision potential for you. But if you have no problem with like few, glare or halo here and there, that would most likely you can get by over time, then but you want to have a good range and least dependency on readers, go with the multifocal lenses or EDOFs, and of course your surgeon will review all those options with you. So I'm glad I had this discussion and I'm happy to answer any questions that you might have.
I think there was one, Dr. Rouhani, I think you touched on it, but somebody asked if Medicare does pay for any of these advanced lenses, and if not, what does it pay for or cover?
So Yeah, so when we have, sorry about that. So let me just go back to my, yeah, so as far as the coverage goes, the physician fee, the surgery center fee, all of these, they're gonna be covered by insurances. Of course, the deductibles and co-payments are there, but for advanced technology lens implants, insurances, unfortunately, they don't cover that for patients. So for the lens implant itself, then it's going to be out of pocket costs for. Um, and there are different costs for each, like light adjustable lens will have a lot of post-op care, and they're all provided to patients free. They're included in the package, um, as well as any other lens implants that we use. So the post-op care will be completely, covered for them. But the lens implant itself, if they want to go with more advanced technology, will not be covered by any insurance as of now. Anything else? Oh, I cannot hear you, Gabriel. Sorry.
Sorry. Dr. Mahdi had asked how many on average UV sessions do they need after LAL?
Right. Okay. So that's a great question. So somewhere between 2 to 3 treatments for UV light, and then we have 2 sessions for lock-in. So we always tell our patients there will be about 4 to 5 treatment sessions. These treatment sessions can be done 1 week apart, unless, let's say, sometimes patients come and then I see some fluctuation in their vision. And then I look at their eyes, I examine them, I see there's some dry eyes going on or some other things. Then I hold off the treatment until stability is achieved, the dryness or any other thing that's going on is addressed, and then we're going to go to the next step. The key in the meantime is patients need to be wearing glasses that are UV protected glasses, because we don't want the natural UV to change the shape of the light adjustable lens until we lock it in. So the lock-ins are 2 sessions and the treatments are somewhere between 2 to 3.
Thank you, Dr. Rouhani. And then goes along with that. Somebody asked, is LAL lens an option for someone that only has cataracts in one eye?
Yes, definitely yes. Yes, and there's no problem with doing that. As a matter of fact, I have had patients with that. So that actually brings up a very good topic. There are cases that one eye can get light adjustable lens, the other one, for any sort of a reason, cannot. So we can even do that too. So just going by, first of all, we're going to cover the eye that's not being treated. So treatments after light adjustable lens surgery will not affect the non-operated eye. And if they have other lenses in that other eye, like I had a patient who had cone-shaped cornea or keratoconus, but the amount of astigmatism was much higher than what light adjustable lens could adjust for. So I put a toric, monofocal toric, like Aspire toric, improved his vision dramatically. He was very happy, but he really wanted to go with light adjustable lens. The second eye was a candidate for light adjustable lens, and I just did light adjustable lens in that eye, and the overall visual outcome is amazing now.
Thank you, Dr. Rouhani. And then somebody asked, they have LASIK with monovision. What are the best options for them?
That's a very good question too. So at least this is the way that I manage that. If I have patients in their 60s, 50, I have a few patients of mine in their 50s. So mostly cataract surgery is kind of like older ages, but there have been quite a few cases that they are in their 60s or late 50s. I'll look at the age. Because I have found that patients who are used to monovision still using that monovision, meaning they're still having a good near vision, fairly good distance vision, but they have started having some glur and nighttime vision issues because of cataract. Then we can do a monofocal lens and pushing for the dominant eye for distance vision, like the LASIK eye that was corrected for distance vision as distance vision, and then for the non-dominant eye for close-up. However, if patients come to me and they have not had sort of a monovision trial, or they have had LASIK, which made them monovision, but they haven't been having monovision for quite a while because of the cataracts formed, and they even don't remember which eye used to see distance, which eye used to see close up. So that means that their brain is not adjustable to that, or will have difficulty to adjust to that. I would actually use all these technologies that we have available to give both eyes distance vision, intermediate vision also, and then I'll tell them, so they might be in need of readers, but most of these cases actually end up really finding great results with either monofocals, like monofocal Aspire, which is a newer version of monofocals, or if they don't have higher aberrations or irregularity or normal, really good corneas, then we can go with the multifocals and provide what they used to have as far as the distance and near vision goes with those type of lenses, rather than make them monovision and seeing them having trouble adjusting to that after surgery. Now, older patients like 75, 80 and above, I really don't do monovision for them because I have found them having a lot of trouble adjusting to it, finally getting into glasses, still not perfectly happy. I get a lot of referrals for that. Looking at their eyes, beautiful cataract surgery is done, no problem with the surgery or the technique or anything, but they cannot just adjust to it. And we do all of these things to lower the chance of lens exchange, meaning sometimes, very rarely, thankfully, we need to go ahead and remove that lens that patient is not happy with and put another new lens in their eyes. We do all of these kind of like evaluations and talks and discussions and counseling just to make sure we reduce the chance of lens exchange as much as possible. And unfortunately, a lot of these patients that have to go through lens exchange are the ones who chose to go with monovision, and they don't get adjusted to that afterwards. So we have to go ahead and take out the lens and then give them a lens with measurements that give them kind of like a same vision that the other eye has, meaning push and target for, like, let's say distance vision for both eyes, and then have them use readers for reading. So it's patient selection, which type of groups, which patients are used to it. We call it neuroadaptation, how their brain can get used to it. And that's the discussion that I always have with my patients when they kind of like say, okay, what if you just make one eye for distance, one eye for close-up, so I'm not going to pay for multifocals. That's a monofocal lens, and then I'm going to be free of glasses. But that's not how it goes. That's how much they can, get used to it.
Thank you, Dr. Rouhani. And we do have a few more here. Somebody said they heard there are two types of cataract procedures. One is done with a laser and one is done by hand by the doctor. Is that true? And if so, are there any differences in the end in terms of results or cost differences?
Of course, very good question. First of all, both of them, surgeon still does use their hands. The femto-assisted laser cataract surgery, which is a laser-assisted surgery, it's called laser-assisted. That means that part of the surgery is being done by the laser. Of course, the surgeon will guide that laser. Not every single step of the surgery is done by the laser, but the very important parts are done. But it's per surgeon selection. So I still, with the laser-assisted cataract surgery, made my own incisions with my own hands. But for opening up the capsule of the cataract or breaking it into pieces, I use laser, and that adds more precision and safety as compared, especially with dense cataracts or more advanced cataracts, as opposed to my hands kind of like being used to make it into pieces and removing it. So it's just about like adding more precision and safety, especially in
dense cataracts, is a very good option. Unfortunately, it's not covered by insurance, so the laser part will be out of pocket. Outcome, again, is going to reduce the time of the surgeon being in the eye, so faster recovery, less of inflammation is going to be there. Usually, kind of like hand, just the basic cataract surgery and the laser assisted should kind of like be eventually the same. But again, it's about the matter of how fast patients heal, the time of the surgery, and how fast we can quickly finish it up. The more we stay in the eye, we have to kind of work on the cataract. Will increase the chance of inflammation and a little bit longer process for healing. But both of them are available. We do those here at Harvard Eye. All of our cataract surgeons, they do both femto laser assisted cataract surgery and just the surgeon assisted. Just the surgeon based surgery. But definitely the surgeon is the one who is going to run the laser and is going to finish up the laser cataract surgery as well. So it's not just like, let's say, LASIK or just something that purely is laser, but it's laser assisted.
And then next one, it says, after surgery, what determines if I will have halos during night driving or not? Is it determined by which lens implant that I have?
Yes, it is, well, before surgery, we will know by choosing the type of a lens implant, that how high would be the risk of developing halos or glare after surgery. Now, do every patient get halos and visual disturbances or glare after surgery with multifocal lenses? Not necessarily, but they're mostly reported with those type of lenses as opposed to kind of like monofocals or light adjustable lens. There's another thing that we have to, keep in mind too, is the cornea curvature and what we call aberrations. So at cataract evaluation session with patients, I think all the cataract surgeons, or most of the cataract surgeons, they do such thing. I'm not a cornea specialist, so I definitely do cornea evaluation with topography or pentacam to see how the mapping of the cornea will look and how much aberrations we have. Some patients with high order aberrations are more to have glare or halo after lenses. So there's a certain degree that I look at that. I kind of like look at it and see, okay, this is high order aberrations. There's a very high chance of having, visual disturbances or glare or halo. I would actually advise against it. But if the levels on that's why I say exam and imaging on the cataract evaluation session is very, very important. So if those are fine, then it's just a type of a lens that we might get halos or glare or might not get. Like I have patients who have had panoptics and had no glare or halo. I have patients who have panoptics and had highest amount of glare or halo without having any problems with their corneas or aberrations. So that depends on the type, definitely. So we know that those kind of like multifocal lenses, they could be providing or producing a lot of glare or halo based on their design. And that's what has been going on in 2025 on how much technology-wise they can work on what's causing that glare and halo in those patients, because of that type of a lens implant. So they can fix that issue, change the design to a way that the glare and halo will be reduced to a significant degree. And we're hoping to see those new multifocal lenses coming out to have the least, if any, of the visual disturbances in the future.
Thank you, Dr. Rouhani. And then these next questions are related to dry eye. It says, if you already have dry eye, can you still get lens implants, and does it make dry eye worse?
They're all great questions.
So it depends on the stage of the dry eyes. I just finished up with my afternoon clinic, and I had a case who was eager to have cataract surgery, but the corneas in the eye was super dry. Of course, when they have that advanced stage of dry eye disease, I mean, it's easy for surgeons to kind of like move on with surgery and just get the surgery done, but that's not the case. We want the best quality of vision for patients after surgery. In those cases, if you jump into cataract surgery, no matter how great of a surgery we do and how, what a, the best technology to provide to the patient, most of those patients will have trouble healing and having the best vision quality. So preparing the eyes prior to surgery is the key. So if I see such thing, I mean, dry eye disease is generally speaking a very chronic, ongoing condition that will not be cured, in a short amount of time. But preparation, of the eyes for surgery is the key to get them ready for the surgery. So let's say if I have a patient and they're really having advanced cataracts, they're having trouble with the quality of their life because of their vision, and they're really in need of having cataract surgery, there are definitely advanced treatments for dry eye disease to prepare them for cataract surgery. So it's just not lubricating drops. We have to go to prescriptions. We have to kind of like consider amniotic membrane products. A lot of times we have, thankfully, we have access to a lot of different modalities and treatments that we can provide patients excellent care prior to proceeding with cataract surgery to maximize their outcome. So I always stress the importance of how the eye surface health is important to not only achieve best visual outcome, but also make sure that all those sort of imaging that we do prior to cataract surgery is not affected by the dry surface and dry window. So the cornea should be really clear as much as possible to achieve the best calculations and best results from all of these imaging that we do to provide them with the best power of the lens implant, therefore the best vision, not only quality, but also quantity as well. So this is very important. So it might take some time for those patients to get their dryness under better control before we move on. And yes, after cataract surgery, a lot of times patients come in and say, okay, you know what, since I did the cataract surgery, I'm having such a bad dry eye disease. This cataract gave me dry eyes, or I have, allergy to this lens implant. I cannot tolerate it. And since then I have been, having problems. And I think, dry eye disease can show itself in a wide variety of different ways. And I feel like when patients are not treated prior to surgery, there's a high chance of, kind of like activation or flare up of the dry eye disease, or for the dry eye to show itself more. So, in-depth evaluation and examination of a patient prior to surgery is really crucial. And yes, we can expect some dry eye flare up after surgery. And that's why I always insist that I see my patients after surgery for at least the first few weeks. So I usually see my patients 2 days after and about a week to 10 days after. And then a month we'll be back to their optometrists to see them. But in the meantime, I will make sure that I actually address not only how they're healing, but also the dry eyes, because it might escalate for a little while after surgery, and then that's manageable and can be treated, but with proper management and treatment.
Thank you, doctor. And then with Vivity, both eyes adjusted the same. Can you read without readers?
Depends. In some patients, they can, especially those who are nearsighted or have longer eyes. Usually they can. I have had very few patients with Vivity that they need to wear glasses for reading. I have found that like being more engineers, more close-up activity needed, more hours of close activity, or they're really avid readers. They sit and just they want to finish up a book at one night, So they would need readers, but mostly they're manageable. Another thing that I didn't mention is that, like before cataract surgery, a lot of patients, because of how they see, they kind of like tend to kind of like close, hold the hands like close to their face, just very close here, or just very far away from them. After cataract surgery, patients will find where they're going to see the best. Yes, with Vivity, if you hold your hand over here, you might not really see well. So if you hold your book here, so close to your face, it's really not a correct distance. That's not designed for that, to give you that perfect vision over here. So I always tell my patients, just move your hand away from yourself. So I make this example. I say, okay, you go to a restaurant, you grab a menu, you don't have readers, you actually can read it, but just don't bring it up too close. Just go a little bit far away. And you're going to find a way. So the correct, really restful way of holding your arm is like about 90 degrees away from your face. So that should be really helpful. But yes, but if you come closer, that then you're going to say, oh, okay, I have to wear glasses, even though I got vividly, but that's not a correct kind of like a distance. Now that's something that you're going to get used to it, or you're going to find that focal point to give you the best vision. So the chance of needing glasses with vividity is not as high as it's been reported, at least for me, thankfully, I should say, and the patients are very happy. And again, one other thing that should not make you concerned is when I say we do push for 20/20 or push for really clear vision for the dominant eye with vividity, and then take some of that clear vision, not clear, some of that 20/20 vision away, like 20/25 for distance, and give you near with just aiming at, we call like a minus half of a diopter, does not mean that you're not going to be having a comfortable distance vision. You're not going to even notice it because both of your eyes are open and you're kind of like having your activities at distance and near without even noticing one eye is not as sharp as the other eye. This is how naturally we are. If you cover one of your eyes and then the other eye, you're going to see one is actually better for distance, one is better for close up, but that doesn't necessarily mean that that eye is bad, that cannot see the distance better than the other one. It's just functionality at certain points. So overall, very happy with how Vivity has been providing really good results for patients.
Okay. And someone asks, what is intermediate vision and what is the range for computer usage?
Yeah, well, that's based off preference. Computer is counted as intermediate, so technically, if you sit on a chair and then put your kind of like our arm aside and hold it close to you, this is near vision. But of course, some patients need a certain near vision based on what they like to do, not just reading, but also activities. Like let's say artists or those who paint a lot, they have intermediate distance, not close up. So they want to really have a perfect intermediate distance vision corrected. So computer distance is counted as um, like like a little bit over an arm length away from you, technically. Just a little bit or just a complete arm length from you will make you kind of like notice how intermediate it is. Or I ask my patients, I say, okay, you're driving in your car, do you see the dashboard well? That's actually intermediate vision. And they say, yes, everything is very clear. So dashboard, when you use, driving, or your computer is counted as intermediate vision. And most of these lenses, monofocals, multifocals, extended depth of focus are kind of like very helpful with that, if that's what your job is. I have a lot of my patients, they come to me and say, I don't care about distance, I don't care about my close-up vision, I do care about my computer distance vision because I'm on that for all the time. So that's how we kind of like look into that.
Okay. And then two more here. Can you wear contacts after implants? And also, does Medicare with a Part A supplement cover costs?
For the contact? Um, First of all, you can wear contacts after cataract surgery because contacts go over cornea. Your lens implant is inside the eye, it's behind the color part of your eye. You're not going to see it. And just putting contact lenses will not affect that. Some patients will be in need of contact lenses. There's the same ones that are going to be in need of glasses. So you can choose between glasses and contacts, and your optometrist will help you with that. As far as the contacts go, I think that's a very good question for our optometrists out there to kind of like tell them. I think, as far as I know, after cataract surgery, glasses, the first glasses are provided to patients free of cost. If I'm not wrong, I cannot, kind of claim that for sure, especially with Medicare Part A. But again, we can kind of like, I can ask our optometrist or my colleagues outside of Harvard Eye as well, and at Harvard Eye, to get more information about that and provide it to patients. But contacts or glasses after cataract surgery can be worn based on the eye needs. Anything else?
Okay.
I
And
think we
then,
have Dr. Amadi on board, so maybe, I don't know whether she's still here or not. Thank you for joining, by the way. But if she is there, she must know about this. But anyway, I will provide more information to patients once I actually talk to our optometrist.
okay.
Because the contacts and glasses are done by the optometrist after cataract surgery is done. Any other questions that I can answer?
Yeah, and then one of them to go along with the last one, it was does Medicare Part A supplement or cover surgery costs?
The surgery costs should be covered. So our counselors provide all the information to our patients. Again, deductibles, copays, all of those things are there. That's what our surgical coordinators will touch base with your insurances and figure out all the costs that you might need. That's one thing that they're going to provide you with all the information. But mostly Medicare hasn't kind of like, we haven't had any problems with Medicare covering the cost of the surgery and surgical center. It's just about like the laser assisted cataract surgery and any kind of like premium lens implants that we choose to do for patients, and that would be out of pocket. Anything else?
Yeah, I think that's it. If there are any additional questions, feel free to email marketing@harvardeye.com and we'll be sure to get those answered for you.
Thank you for joining us tonight.
Yeah, thank you so much for the wonderful presentation, Dr. Rouhani, and thank you to our guests who attended. We hope to see you at our next webinar event, and have a great evening, everybody.
Thank you. Have a good night.